brief intro to the group and what we're doing in Palm Beach County. This is an 80-physician, multi-specialty group, half primary care, half medical specialists, spread over 29 locations covering the full range of medical services. And what our leadership recognized some years ago is that the platform that we were built on is burning. And the burning platform involves revenue. It also involves measuring outcomes. And as the other speakers have said, we're transitioning to a healthcare platform that maximizes quality, improves outcome, and minimizes the cost. And so we've explored several options, and I would say that we're pleased to participate recently with the Palm Beach ACO. But the option that I'd like to talk to you today about is the Management Services Organization and the Medicare Advantage space. And I'm very pleased that our initial speaker this morning, Dr. Goldsmith, suggested that the Medicare Advantage space may be the direction that we're drifting with the best structure and the best possible outcome. We certainly believe that as well. So let me jump in and give you the formula in the Medicare Advantage space, and it's really basically a simple formula. It involves revenue minus cost, and it leaves a cost savings. And so I've listed the factors in the revenue equation for you, and it basically is the annual premium for all of the patients. And that's calculated by the number of patients in your pool. It's calculated by the MRA score, which is the Center for Medicare and Medicaid Services way to risk adjust the patient population, meaning the sicker patients result in a higher premium. And so from our standpoint as physicians, we need to document exquisitely the conditions that our patients have so that we can be reimbursed properly on the revenue side. And we've heard Kelly mention the STARS rating and the HEDIS rating. So HEDIS is the Health Effectiveness Data and Information Set, which is 80-plus measures over 5 domains. It is the current measure of quality. Some of the speakers have suggested this may not be the best measure of quality, but it's what we're working with now and can be measured on an individual physician basis or a practice basis or a healthcare plan basis. And lastly, the 5-star quality measure also, which is basically a consumer-driven simplification of several factors of a practice or a health plan that involve, staying healthy, managing chronic diseases, and some of the member experiences and impressions and feelings about customer service of the plan. And each one of those factors will adjust the revenue into the Medicare Advantage plan. And of course, we subtract the cost, which involves the utilization by the patient to the emergency room, to the hospital, for diagnostic procedures, for their pharmacy services, for the tests that we order as physicians. And the goal for the Medicare Advantage space is to influence this continuum of care. And again, the question has been brought up several times, who is the leader? And really, we believe the physicians are the ones that can really influence this continuum of care. And what's left over at the end is a surplus that's sort of value-based and a surplus that we can share in. So I'd like to contrast our model from yesterday to today. And yesterday's model for our group was fee-for-service, where we code, CPT code, and somewhere between 30 and 60 days we get a return. Some of those quality metrics that I measured were there, not quite as important as they are today. And what we have today is the Medicare Risk Adjustment Score, the specific coding and documentation that I mentioned, but a revenue cycle that is 6 to 9 months in duration. In the yesterday, we had a volume-based practice, but now we have a value-based practice. To continue to contrast the way we deliver care yesterday and today, yesterday's focus was on episodic care, so those visits where the patient came in and we dealt with whatever problem they presented to us. Today's care is multidisciplinary and it's coordinated. And it's coordinated over the continuum of care in all the places that I mentioned previously. Yesterday's patient interactions, again, were episodic and a little bit inconsistent, but now the coordination of care is designed to maximize quality, to improve the outcomes, and to minimize cost. And so we have a complex care coordination team and some innovations, and I just summarized them for you on this slide. And the first one is we need to identify the high-risk patients. And the rule of thumb is that 20% of the patients spend 80% of the money. And so if we can provide a concierge-like service to those patients. We will minimize the bad outcomes and minimize the expense. And the concierge service means speaking to those patients often, either the physician or the physician care extenders. It's a little bit hard in the culture change to value-based medicine to explain to physicians that they might need to make several phone calls or make several visits. But in this model, there is satisfaction and reimbursement for that type of service. Population health has been mentioned several times today. So we believe that by managing data and statistics on the patient's hemoglobin A1C, as Dr. Rasway mentioned, or other factors for lipid control, as we heard this morning, or hypertension, that we can coordinate this care in a much more efficient way than we did previously. We look at this whole pipeline of care through our EHR. And so we understand that the EHR is a difficult proposition for physicians, but I can assure you the EHR is the method in which we collect and analyze data. And that data is a valuable tool. It's a valuable tool to us in our group and to physicians in general, because if we don't tend to that data, somebody else will. So we watch that data and we do predictive modeling. And so we hope to be in a position soon to be able to anticipate healthcare interactions before they happen. And lastly, we want to watch this whole continuum of care and make some effective interventions before hospital admissions, during hospital discharge, and as the patient returns to their primary care physician. And so we believe we have several advantages. This is a physician-owned entity since its inception, so not controlled by outside entities. It's a multi-specialty group, and I'll tell you, the focus on value-based medicine has often been on primary care, and I think that is well-deserved and due. And so those primary care physicians have to interact with specialists at some point. And our group has primary care specialists as co-owners and co-providers in the group. We have the flexibility to grow, and we are open to grow, and we are a local organization in Palm Beach County that would like to service the county and interact with as many physicians as possible in this county, in specialties that we don't provide and specialties that we do provide in areas where we can't provide that service. We believe we have the freedom to choose our partners, and those partners include hospitals and post-acute centers and home health agencies and pharmacies. And we'll choose those partners based on the measures that I've already mentioned, the cost and the outcome. We have the ability to, again, change utilization patterns based on cost effectiveness, and through all this, maintain our independence and some leverage in this marketplace. And so really to summarize, I would say that we're again influencing the physicians in our group, or influencing the entire continuum of care for the first time. We're watching this revenue cycle, which is crucial for the success of the program. We're trying to align incentives across the entire system. We're focusing heavily on those frequent utilizers to improve their outcomes and to reduce the expense to the system, and trying to effectively promote a culture change, really, within our group and our county to embrace this new paradigm. I appreciate your attention. Thank you.